So, good morning, everybody. We'll continue the study of the heart diseases cases today. And just have a few points in the beginning of our lesson. What have you understood so far? If we have the stethoscope and we hear a murmur in the heart, which part of the heart is problematic? And you hear a murmur in the stethoscope. Where do you have to look for the cause of this? Yes? The valves and the endocardium. Yes. Endocardium. If you have a patient with dyspnea and you have a severe stressing of the pulmonary circulation, which part of the heart should you check? The left side of the left. You have pulmonary congestion. So the left heart is, you have to look. What could that be? It could be a mitral valve stenosis. So the blood cannot go to the left ventricle. It could be mitral or aortic valve insufficiency. So when they close, some part of the blood comes back and stresses the pulmonary circulation. However, in this case of pulmonary circulation congestion, it is logical that the pressure is increased in pulmonary circulation. How can you find that with a catheter? Which pressure is to be counted, and it will represent the amount of stress in the left atrium? Which pressure is that? Yes? The pressure of the wedge pressure, that's right. However, if you have a separate cause of pulmonary hypertension, that means a lung disease, long-standing lung disease, like emphysema, and the lung is filled with air which cannot go out, cannot be excreted. In this case, the pulmonary wedge pressure won't be affected because the pressure in the left atrium will not be increased. Which pressure will be increased in this case? That you have a pulmonary hypertension not related to stasis due to left heart insufficiency, but due to other causes. Which pressure will be increased? You put your catheter and you'll count the pressure where? This will be the pulmonary artery pressure. All right? Not the wedge. The pulmonary wedge pressure represents the pressure in the left atrium. Measuring the pressure in pulmonary artery is a sign of pulmonary hypertension, not related to left heart malfunction. All right? Think, yes, please.
I didn't understand why we were talking about the pulmonary pressure with regards to...
We have not started the cases yet. We have an introduction and understand some things so that we'll understand the cases better. The first case is irrelevant to what we are talking now. Next, think that there is a shunt between the cavities of the heart, the left and the right. If the shunt goes from the left to the right, how is the patient affected? If there is a shunt from the left side of the heart to the right, which circulation is stressed? From the left to the right. There is much more blood in the right ventricle. So which part of the circulation is affected? Which part? If we have this sort of shunt, because today we'll deal with some defects, anatomic defects in the heart. So, yes, please. Louder? No, because the blood from the left goes to the right. So the right ventricle is stressed and sends more blood where?
To the right side, so the pulmonary circulation.
So the pulmonary circulation is stressed. That's why, owing to this shunt. Now, if we have a shunt from the right side to the left, that means which blood goes to the periphery? There is a shunt directly from the right side to the left, from the right ventricle to the left. Which blood goes to the periphery in this way? Yes? The oxygenated blood. So what will the patient show? Cyanosis. That means that non-oxygenated blood will circulate. So he'll become cyanotic. This is very basic knowledge, which we should know, because this is how we'll explain the cases we see. And we have to stress the minimum of clinical information so that our cases make sense. All right, then. Now, let's go to the first case. You have an autopsy performed, and when you open the thorax, you see this. What is this all material around the heart? What is it? Yes.
Blood.
It's blood. So this is hemopericardium, and the blood is, the quantity of the blood is so big that it had tamponade of the heart. That's why the patient died. And its history: 3 hours of chest pain 5 days ago. 5 days ago. Now she has an abrupt loss of consciousness, and we have the creatine phosphokinase isoenzyme not elevated, but the troponin 1 level modestly elevated in her serum. And we have this autopsy patient. So what happened most probably to this patient 5 days ago, which however did not lead her to seek for medical attention? What happened? Probably. You can say anything you like. There's no problem. But think and say anything you like. If it's wrong, it's no problem. No problem with me. Okay? We'll make it right together. What happened? Yes?
A thrombus in the coronary circulation.
There was a thrombus in a which circulation?
The coronary.
The coronary. So that was an abrupt onset of occlusion in the coronary artery, a branch, and it had myocardial infarct. So what happened next? The period is 5 days after the onset of the acute myocardial infarct. Remember from our last lesson, which tissue is formed now, is being formed now in the area of coagulative necrosis? Which tissue is formed now? Early granulation tissue. That means it's not a scar that can endure stress. So what happened most probably, and we have this finding of hemopericardium?
Rupture.
A rupture. There was a rupture in the site of the infarct, the acute infarct. That's why the troponin 1 level is still increased, because this enzyme raises, and it's about 1 week or up to 10 days after the onset of the myocardial infarct. It is elevated in the serum, whereas the other one, the creatine phosphokinase isoenzyme, raises much earlier, and its value decreases early enough. So that's why at this time point, 5 days after the onset of the acute myocardial infarct, only troponin 1 level is increased. And you want to ask me something? Yes, please.
I understand. Does the infarct lead to aneurysm or?
No, it didn't have time, because in order that an aneurysm of the left ventricle is formed, The patient has to survive so that in the place of the extensive coagulative necrosis, scar tissue will form, and having to do with the pressure of the blood, the scar tissue will, the continuity of the wall will remain. It won't rupture like here. However, it will become weak. And so it will form a sac, and this will be the aneurysm, which will have some blood. And what will be the subsequence? The blood that the heart sends to the periphery is diminished. And of course, there is a risk that it ruptures as well. Not so much, it's not so dangerous like here of the rupture of the area of early inflammatory granulation tissue, where we have the necrotic myocytes, polymorphs, and macrophages with their enzymes lysing the area before the organization of fibrous tissue. This will come after this phase, because macrophages will secrete fibrogenetic factors, and then a scar will be formed there. Yes, you want to ask me something?
Does the early inflammatory granulation cause hardening of it? Is that why there's...
No, it's not hard, no. On the contrary, it's very soft. That's why it ruptures. Yes. So that was our first case of a complication of an acute myocardial infarction. Now have a look here at the lung circulation. What is problematic in this image? What is there in the lung alveoli? What is there in the lung alveoli? Remember what we said in the previous semester. If the alveoli are filled with fibrin and inflammatory cells, this would be pneumonia. But that's not the case here. However, the alveoli do not have air. There is something else filling the alveoli. Is it an inflammatory exudate? No. There are no inflammatory cells nuclei there. So what can this be? Related to what you see in the septae. Have a look here. Look at the septae. What are the capillary vessels here filled with? What are they filled with? What? Red blood cells. So there is a congestion. There is a congestion in the pulmonary circulation. Do you think that this is due to pulmonary hypertension or to left heart failure? Most probably, this is pulmonary edema being related to something that happened in the left heart. What could that be? A stenosis in the mitral valve, a problem, a stenosis in the aortic valve, an infarct destroying a large amount of the myocardium of the left ventricle, so it cannot send blood to the periphery. So where does blood stay? It stays in the lung. And this is pulmonary edema. And what can we see here? Have a look. The cardiac output is diminished. The right atrial pressure is increased. The pulmonary arterial pressure is increased. However, which is the key finding dealing with the situation of the left atrium, the pulmonary artery wedge pressure. You see, it is also significantly increased, so the problem is in the left heart. Okay. So we found the underlying mechanism here. We've described this is congestive left heart failure, and we stressed the significance of the pulmonary arterial wedge pressure counting, and that's what increases first. However, if this disease becomes chronic, the other pressures will be secondarily affected. Not from the beginning, but if this level of pulmonary blood circulation congestion persists, If it persists, the other pressures, that means the pulmonary artery pressure, the right atrium pressure, will be secondarily influenced. Okay? Now, this one here. This is a histologic image of a hepatic lobule, and we see zone 3. What does zone 3 means in the hepatic lobule? It's the central vein. So what do you see around? What do you see around the central vein? There is increased congestion, and hepatocytes become necrotic. So which enzymes in the patient's serum will be increased if we have destruction of hepatocytes? Which enzymes in the biochemical examination of the patient's serum will be increased? Yes, transaminases. All right. So now, how can this happen? Where is the problem here? Taking into account what we have already mentioned at the beginning of our lesson. Where's the problem? And the liver becomes so congested in the central veins, as well as the hepatic veins are congested, the central veins are congested, and this stasis, where will it be transmitted? What will happen in the peritoneal cavity? The portal vein will secondarily be involved as well. So this congestion will lead to what? What will gather in the patient's peritoneal cavity? Since we have a congestion and the blood cannot circulate and leave the liver and go to the right heart from the lower vena cava. So what will happen? Yes? Excellent. It will be an accumulation of fluid in the peritoneal cavity, and this is called ascites. Yes. However, the liver won't be cirrhotic yet. It will be due to which part of the heart does not function well, and we have all these congestions at the periphery. Which heart? Right. The right. So there is a problem in the right part of the heart cavities. And how is this related to the chronic lung disease of this patient? This patient had severe emphysema. That means an obstructive lung disease where there is functional obstruction in the lung, and the lung is filled with air. It's like a barrel. However, the septae are not strong enough, as they are broken into pieces due to a disbalance between the enzymatic procedures of protease, antiprotease, but I won't go on because that will be, for next week, we'll have the respiratory system. However, there was a chronic lung disease which affected the pulmonary circulation. Is it edema, pulmonary edema? No. The left heart functions well and sends blood to the periphery. So this is pulmonary hypertension. It was caused by a chronic lung disease affecting the pulmonary circulations. And can you tell me another cause of pulmonary hypertension having to do with the heart? We mentioned it at the beginning of our lesson. Is when we have left to right shunt. And the amount of blood is increased in the right ventricle, so there is an increased amount of blood in the pulmonary circulation, and we have pulmonary hypertension. However, this is not the case here. Here we have a lung disease, chronic lung disease, affecting the pressure in the pulmonary circulation. So, what happened to the heart? We have jugular venous distension and increased liver span. The liver has increased in size because it's filled with blood. The blood cannot circulate through the right heart, so we have congestion. And this is called cor pulmonale. That means right heart insufficiency due to a chronic lung disease in this instance. Yes?
Can you explain why the right side of the heart leads to pulmonary hypertension?
It's not the case here. However, if there is a shunt, that means an increased blood flow through a defect in the structure, most probably of the septum between the two ventricles, and the right ventricle becomes overloaded with blood, where does this lead? It sends the blood through pulmonary artery to the pulmonary circulation, so it becomes congested, not in the way it became in the context of pulmonary edema, where the left heart did not function. It's not the case here. The right ventricle is overloaded due to the shunt we referred, so this affects the pressure in the pulmonary circulation.
It's only through a shunt that this can be possible to the right side of the heart?
I think so. I think so. The cases of pulmonary hypertension leading to cor pulmonale and right heart insufficiency and congestion is most probably lung disease, chronic lung disease, possibly multiple pulmonary microembolisms, which, however, do not cause the death of the patient. Small microembolism increase pulmonary circulation pressure, and a shunt from the left side to the right. These are the main causes of pulmonary hypertension affecting the right heart of the right part of the heart, which becomes hypertrophic. Now have a look. This is a patient who had congestive heart failure, and rather of a mixed type. What does this imply? A mixed type of congestive heart failure due to the insufficiency of the left heart. What will the patient have as an indication of heart failure, of left heart failure? What will the patient have? What do you think? Because it says here that he had, it says, which of the symptoms there is related to left heart failure? Have a look at the symptoms. What do you think? That's right, dyspnea. That means because there is stasis in the pulmonary circulation because the blood cannot leave the left ventricle of the heart. But also we have lower extremity edema and pleural effusions and possibly jugular vein distension. This, which part of the heart has been affected? Which part of the heart? And we have edemas, symmetrical edemas on lower extremities, symmetrical, increase in the size of the liver, collection of fluid in the peritoneal cavity, ascites. Yes, which part?
The right.
The right. So this heart disease, because it's a heart disease, affected both sides of the heart. And what do you see on the endomyocardial biopsy? There are some fibers which are somehow affected. But what is the main finding you see here in the tissue of this patient? And this may somehow be related to another sign of the patient that we'll discuss shortly. So what do you see? What are these blue dots between the degenerated muscular fibers? What are they? Yes, please. Excellent. They are inflammatory cells with round nuclei, that means mononuclear cells, without cytoplasm, so they are not plasmacytes, they are not macrophages, they are lymphocytes. And these lymphocytic collections are dispersed throughout the heart. So what do they affect? Remember what we said on the previous lesson from the periphery of an infarct, where we have the inflammatory cells affecting the adjacent myofiber, myocytes. What did this cause? If we have inflammatory cells, like here, because this is a case of myocarditis, and we have them between and around myocytes, what will this cause to the patient? And it is reported in the patient's history. What do you think? What will it affect? Yes?
It will affect the electronic signals in the heart, causing...
The rhythm. It will cause arrhythmias. This is the histologic basis of arrhythmia. That means something affects the transmission of the signal, and in this case, the affected by the inflammatory infiltrate myocytes cannot do their proper contraction. So this is a cause of arrhythmia, and in this case we have atrial fibrillation. So if we have arrhythmia in the atrium, and think of the left atrium, what can form there? What can form there? Because if we have arrhythmia, the blood does not circulate properly, so what can be formed there? Thrombi, and the thrombi leave, they go to the left ventricle, then they pass to the aorta, and they cause embolisms. Either they go up the carotid arteries and you have a stroke, or they go down the celiac artery and you have the splenic infarct, the bowel infarct, the renal infarct, and so on. So this is the case of myocarditis, and since you see that the inflammatory infiltrate with dispersed inflammatory accumulations of inflammatory cells, they are not like the case of the infarct where the whole inflammation is confined to the coagulative necrosis, to the part of the heart that was acutely ischemic and necrotic. Here, in myocarditis, they are dispersed. And when you see that the cells forming the inflammatory infiltrate are lymphocytes, in case there is an infectious agent involved, what would that be? Would it be a bacterium? No, they are not polymorphs. So what would that be? What would that be? And you see inflammation with a lymphocytic infiltrate. And let's suppose that it's of infective origin. It's not necessarily so, but we'll suppose it is. So what will cause? Which infectious agents cause a lymphocytic inflammatory infiltrate? Which agents? The viruses. So the most common infection in patients with myocarditis has to do with Coxsackie viruses. All right? And is there somehow to diagnose a viral infection through the immunoglobulins circulating in the blood? What class of immunoglobulins will be increased if we have a recent virus infection? Have a look at all the viruses potentially involved. You see here, Coxsackie, cytomegalovirus, a lot of them. So, what will you count for each of the potential viruses involved? What will you count? What will you find?
Rise in IgG or IgM.
That's right. You'll have IgM, which means that it's a recent infection, or if it is a reinforcement of an old infection, viral infection, you'll find increased titers of which? Of IgG. All right? So there is a possibility, especially as far as cytomegalovirus is involved, that there is an old infection, so there won't be IgM antibodies, an old infection, which somehow the patient's immune system was stressed, and so the old infection became active again. In this case, you'll find increased titers of IgG immunoglobulins. So this is the case of myocarditis. With supportive care, the patients do well. However, in rare cases, there are arrhythmias which cannot be controlled, and the patient may die, and we have that necrotomic finding. This is a rare case of a pseudocyst causing myocarditis, and it has to do with toxoplasma. Quite rare. Now let's have a look here. This is the autopsy specimen of a heart weighing about 500 grams in a patient which was stressed during some sort of a game, of an athletic procedure, and he had a syncopic episode. He lost consciousness and died. So what do we see here? We see an increased size of the heart, some sort of a disformation mainly affecting the septum between the two ventricles, and we have a wrong configuration of by the echocardiogram of the left ventricle, meaning that it cannot be filled well when we have the relevant time in the heart functioning, and it cannot send blood when we have the heart sending blood, this phase. So this case correlated with have a look at the normal heart myocytes, myofibers architecture, and see how disrupted they are. And we have this tissue forming around these disarrayed myofibers with a Masson stain. So what tissue is this? The blue one that is highlighted with Masson stain. What tissue is it? Fibrous tissue. All these findings are compatible with hypertrophic myocardiopathy. The histologic findings are not specific for this type of myocardiopathy. However, they are frequently observed. So hypertrophic cardiomyopathy. So in everybody who wants to become stressed, to get stressed during an athletic procedure, he should examine his heart or her heart, also with some method of showing the formation of cavities, not just a mere auscultation of the heart is not enough. Yes?
In
hypertrophic cardiomyopathy. It's a genetical disease, and you'll study the genes involved. Yes?
we have the myocytes increasing in size to
Logically, yes. However, it's not so specific, because in this type of cardiomyopathy that we'll see now, again, we have the same findings. However, in this case, it's not the hypertrophy of the septum between the ventricles. It is the main finding is the dilation. The main finding is the dilation of the cavities of the heart, mainly of the left ventricle, and this is how is it called? Let me have a look. Dilated myocardiopathy. All right? And you see how the ejection fraction is involved. You see how low it is? What does this mean? That the heart is too dilated, like in the previous case, it was deformed and hypertrophied, so it does not send enough blood to the periphery. So this is, you see the findings are more or less the same, myocyte hypertrophy and interstitial fibrosis. There is a genetic base, however, in cases where we have chemotherapy. You are aware of trastuzumab, that means targeted therapy for breast cancer mainly, when there is a score of HER2 3+, you have score 3, you give Herceptin, and this could be cardiotoxic. And that's what it is, it may cause, all right? It may cause dilated cardiomyopathy. And of course, there are other causes. You see a past viral myocarditis can lead to dilated myocardiopathy. That's another cause. Alcohol abuse and other more rare causes. Now have a look at the valves, at the valve of the mitroid. You see the vegetations. However, they are not the vegetations of the infectious myocarditis we've studied in our previous lessons. These are related to a history of painful pharyngitis 3 weeks before. So, since we have a pharyngitis, which is the infectious agent most probably causing the pharyngitis? Yes? A bacterium, and most commonly among bacteria, Streptococcus. That's right. And this causes a sensitization. You see, infection with group A Streptococci. It has an antibody response against bacterial proteins, and this is immune-mediated endocarditis. So, if we have endocarditis and we have the mitroid valve affected, that's the murmur. You listen when you examine the heart. Arrhythmia, because this rheumatic disease can affect the myocytes as well. And pericarditis, which is clinically evident with the friction rub. What is the friction rub? The infiltrate gathering in places of the body where we have cavities lined by mesothelium, such as the pleura, the pericardium, the peritoneum. These inflammatory infiltrates are rich in fibrin. So, if they persist, they make strictures between the two layers. So, the heart is trapped in this sac, in the pericardial sac, so there is not enough space for it to move, and this is a finding, you listen with your stethoscope, of a friction rub. That means the two layers of the pericardium are connected to each other because the inflammatory infiltrate may have been with low protein quantity, serous in the beginning. However, as it is formed under such surfaces, fibrin is prominent, and this forms strictures. It's quite the same after surgical procedures in the bowel. Strictures may be formed, and they will press the bowel from the outside, and you have obstruction, something similar to what happens in the peritoneum, and something similar to what happens in the pleura when, if you have an inflammatory infiltrate and it forms strictures because it is rich in fibrin, if you cough or you breathe very deeply, the two layers of the pleura are connected with the strictures, and so you have pain. This is pleuritic pain, as we'll see in our next week in the respiratory cases. Have a look. This is another consequence of rheumatic heart disease. Now, look at the mitral valve. What does it look like? It looks like the mouth of the fish. So it is stenotic. What will the patient have? What will the patient have? He has stenosis of rheumatic origin, as most common is in adults, of the mitral valve. So what symptom will this give to the patient? Think of what we said at the beginning of the lesson. If we have some problem of the blood leaving the left heart to the periphery, where does it go? Dyspnea, of course, because there will be congestion in the capillary vessels of the septa between the alveoli. And if this is not in some way treated, pulmonary edema will happen. So this is stenosis of the mitral valve. And similarly to the mitral valve, the aortic valve, here having three cusps, as it should have, it is affected. However, it is affected by these deposits here, which is calcific aortic valve stenosis. It most often happens when the aorta has two leaflets, but it can happen when it has three as well. So the blood cannot leave the stenotic aortic valve. The left ventricle becomes hypertrophic because it is stressed so that the blood leaves the heart. And we have a left-sided congestive heart failure affecting the lungs and dyspnea as well. Oh, here we have a severe chest pain, very severe, and have a look what has gathered around the ruptured segment of the aorta, which if it is low enough before the arc, it causes hemopericardium and possible cardiac tamponade as a cause of death. So what is this? Have a look at the blood here. And where did this blood go? It's quite similar to a dissected aneurysm, where the blood goes to a false lumen, and so it is lost. It cannot go to the periphery. And this is a cause of death if not treated immediately. There are some predisposing factors, such as diabetes mellitus and hypertension. And this is a very severe chest pain, which in a patient with a history of hypertension, he becomes hypotensive. Why? Because he has lost all this blood. If you lose blood and you go to a situation of oligemic shock, then the pressure lowers. So he becomes hypotensive due to the aortic dissection. And the last cases will be briefly discussed. This is a single defect, not related with other malformations, between the two atrium. an atrial septal defect. And why does the patient have jugular venous distension and increased hepatic span? What signs are these of what type of heart insufficiency? Right. So the shunt will most probably be from where to where? So that the pulmonary circulation is overloaded, an increased amount in the right ventricle causes the congestion. The left side is not abnormal. Yes?
How can the shunt be from left to right?
It happens. It has to do with the difference in pressures. However, in this case, if the difference are low, this may take a long time to establish. Because look here, if you study the case, we have pulmonary hypertension. You see, years can pass with left to right shunt. And we have the complications here, and it can close spontaneously. However, not from the atrium, but from the ventricles, it closes spontaneously. Here is another case. We have cyanosis and congestive heart failure. So cyanosis is a sign of right to left. So let's see what happened here. There was a large ventricular septal defect, and we had ventricular hypertrophy. However, after some time, we had the right to left shunting known as Eisenmenger physiology that caused the cyanosis. But initially, it was left to right. That's why we had the pulmonary hypertension and cor pulmonale. This is very interesting because we have the transposition of the great arteries, and you see the aorta here, it arises from the right ventricle, and the pulmonary arises from the left. So in this case that we have such close circuits, how will the blood be oxygenized? How will it be oxygenized? Because it will be oxygenized owing to one structure that should have closed when in the newborn. However, in this case, it remains functional. And which structure is this? It's the structure joining the aorta to the pulmonary artery. From your embryology classes, do you know what this structure is called? Which here, the function of these structures persists during birth. How is it called? No problem. That's why I'm talking about theory. You know my belief, know that. That's right. Now that you see it in the patient, you'll remember it. You remember that it is open. If you read it in the textbook, you forget, because it's not related to your job, to what you do every day. That's my way. It's okay. Be patient. Patient. So it's patent. Have a look. This structure, patent ductus arteriosus. Next. Here. This is phallotetralogy. What is there? There is a big defect between the ventricles and the overriding aorta, and there is a stenosis. There is a stenosis in the right ventricle leading to the pulmonary artery. So what will the patient have? Cyanosis. Because the shunt will be from right to left. However, this pulmonary stenosis prevents pulmonary hypertension, as you can presume. This is stenosis in this part of the aorta related to Turner syndrome, all right? postductal aortic coarctation. And here we had symptoms of looking like mitral valve stenosis. However, it was a tumor in the left atrium. And have a look at this tumor. You see there is a lot of matrix and stellate appearing cells relating to the mesenchymal nature of this tumor, which is a cardiac myxoma. Of benign nature, however, it should be surgically treated so that some parts of it may not break and become emboli. All right, thank you very much. See you on Wednesday.